we're going to start with the creators of the program in West Virginia called Farmacy, F-A-R-M-A-C-Y. Dr. Carol Greco is actually Antonelli Greco. She was Antonelli when I first met her here at WVSOM. Graduate in 1984, married the head of internal medicine up at Ohio Valley Medical Center. You all knew of that program at least. So they have been their whole careers, alumni here, but working in the Wheeling area with a variety of projects. But one of Carol's passions, besides it was 4 children, wasn't it, Carol?
Five.
Excuse me, I've missed one count in there. How young is the youngest, or how old is the youngest?
So my youngest are triplets. They're 31.
Oh, that's when the crowd arrived.
Yeah.
Okay. They're 21. Wow. Oh, that's
31.
a good story. 31. Oh, 31.
Yeah.
Well, you said it. I didn't want you to know them to know that you got pregnant at 14 or 12 or whatever age you're talking about. So you can read about her bio here, but she's been very involved with this farm to table and food thing, and I'm not going to give away what they do, but with her is, I guess, right arm and left arm, both Amanda Cummins. And Amanda has been just as instrumental in putting this together for the community, this pharmacy program. And I think you'll smile at the concept, but it's an amazing concept that can be used in rural communities around the country and really around the world to some extent. But we're such drug pushers here and prescription writers that it's good to have a prescription that you put in somebody's hand that you feel good about, or especially good about. So Amanda and Carol, take it away and tell something about yourselves personally to fill them in. But the time is yours, and I'll just stay here and answer questions or ask them. Thank you.
Well, thank you, Dr. Foster. We are super excited to be here. Anytime we get the chance to talk about our program, we do it. We jump on it. So this is great, and it's great that you're all interested in rural medicine. We need good doctors in West Virginia, and especially in the rural areas. So thank you for being interested in that program. What we're going to do today is we're going to talk a little bit about our program that we started back in 2016. What I thought we'd do is we'll give you our mission statement, and we'll talk about some health statistics in the state of West Virginia. We'll go through some terminology, and then we'll go through a history of the progression of our program, what's developed over the last 5 years. And then in the end, we'll tell you a little bit about how to start your own program if you're interested. So let's start it. It's not progressing here. Hang on a second. All right, there we go. I got my tech support on this end too. Do you have an echo there, Dr. Foster? Are you okay?
I have no echo, no.
Okay, good. All right, so the mission of our program is providing access to affordable, healthy food, as well as basic nutrition, education, and cooking skills to help fight and prevent chronic disease in West Virginia. And let's talk a little bit about our program. It started back in 2016, and we started it in Wheeling, West Virginia, Wheeling Health Right Clinic. Wheeling Health Right Clinic is a free and charitable clinic, and sees a variety of patients that we saw essentially had a very high incidence of chronic disease. And we're talking about diabetes, heart disease, hypertension, COPD. And because of this, we realized that we had to do something else, and we had to get to the root of the problem. We felt that our patients basically were reflective of the rest of the health statistics in the state of West Virginia. And you can see up here, type 2 diabetes is at 16% in the state. Hypertension is at 43.5%. Adult obesity is at 39.5%. And you can see we have it in kids too, even as young as 2 years of age. And that's significant. Look at the 10 to 17 years old kids. They're 20.3% obesity levels. And that's defined as, BMI of 30 or above. So, we always run neck to neck with Mississippi. They're our competitor. But we think that these stats are pretty close for what's going on in 2021. The poverty rate in the state is 19.1%, and that was in 2019. It's roughly the same. It may be a little bit less right now, but we're one of 4 states that has a poverty level higher than 18%. Food deserts exist in 40 of 55 counties in West Virginia, and food insecurity is reported by adults to be 1 in 6 in West Virginia, and kids it's 1 in 4. That's about 20.6% of children in the state.
We wouldn't consider starving people in a, pretty developed modern world, especially in the United States of America, but food insecurity, the true definition is a lack of access at times during a year to adequate food for a healthy lifestyle. So if we, can remember historically, the potato famine in Ireland was still considered a famine because inadequate food is not conducive to living a healthy life. So when we, poll the audience in West Virginia, as the previous slide stated, there's a limited access at times or poor access to healthy foods at times in much of the state. Coinciding with that, food desert is a trendy word and probably not something that we would think of to, again, be referencing in the state of West Virginia, but it's essentially it's a little bit different in terms of definition in rural areas versus urban areas. But if you can imagine, it's limited access to foods, lack of easy access to healthy, fresh food. So just because the town has a strip that includes a Burger King and a Tudor's Biscuit World and Walmart, that doesn't necessarily mean that they have access to fresh, healthy food. And if you can imagine, if a grocery store were to close in a small town, truly what's happened in some of rural southern West Virginia, it would leave that town and that surrounding area to be a food desert. And they can be created overnight when something closes. So it's truly the lack of access to food that becomes part of the health burden in the state of West Virginia. And when we look at the health disparities in the state, this slide is striking. And these are some numbers that you may hear these. You may be in a place where these numbers are repeated, like in your lectures or something. But as someone who's just practiced medicine in West Virginia for about 13 years, these numbers some of them have stagnated, some of them have climbed. So when you look at our state compared to the rest of the country, and this is recent data, 2020, no COVID information in here, but when you look at the chronic disease burden, all of it significantly higher than the rest of the country, specifically with diabetes, of course, COPD, we know that we have a high incidence of tobacco use and abuse. Some of the other statistics which are striking are injury deaths, 70% higher than the rest of the country. Really curious to think about how that plays a role in terms of how we live and what we eat and what we're doing with our spare time, which is potentially why we don't eat very well or how that all ties into it. But overall, these health disparities are calling out to us as health providers in the state of West Virginia. We're not getting any better, and we must kind of begin to look at the origin of our problems.
So I want to talk a little bit about the social determinants of health. And the World Health Organization defines that as a condition in which people are born, grow, live, work, and age. And so when we talk about those conditions, we're talking about income levels and educational levels and basics like clean air, clean water, safe neighborhoods, food insecurities that people might have, and food access that people might have or not have. And so the social determinants of health really make up about 80 to 90% of a person's health. And that's a big, big number when you think about it. And medical care only makes up about 10 to 20%. So if you envision this, the social determinants of health as a pyramid, medical care is way at the top, way at the little tip of the pyramid there. And so we have all these other influences that happen and happen to a person to determine how healthy they are, how unhealthy they are. So then just think about what you're involved in and what I'm involved in. It only makes up about 10 to 20% of a person's health. And we talk about the price of poor health. Here's some recent statistics. And basically these involve healthcare spending and lost productivity. Cardiovascular disease is $351 billion, $351 billion stress on the healthcare system in our country, and lost productivity in industry and jobs. Diabetes is $327 billion annually. And then you talk about obesity, which is amazing. It's 1.72 trillion, that's trillion with the T, annually when it comes down to healthcare spending and lost productivity. So that's amazing. There's one stat that I want to talk about also. That was, it was a study done by Geisinger Health Institute a few years back. They actually started their own pharmacy program about the same time we did. It's an ACO that exists in Eastern Pennsylvania, and they own everything from fruit to nuts. They own, medical school all the way through health insurance programs. But they determined that if you lower a hemoglobin A1C by about just 1 point for a diabetic, you're going to save essentially $8,000 annually for that diabetic. The other thing we want to talk about is the poverty-obesity paradox. Factors like poverty, food insecurity, the food deserts that we just talked about, they all contribute to a person's health, their obesity, their chronic disease levels. And patients that are diabetic, well, I should say patients that are food insecure and nutritionally insecure, which means they may be eating, but they're not eating healthy foods, are about 2 times as likely to develop diabetes than people who do have food security and can eat healthfully. And why is that? It's because when a person doesn't have access to healthy food, fresh produce, fresh meats, then what do they turn to? They turn to cheap processed foods. They're high in sugar, salt, and fat. They have absolutely no nutritional value, and that creates the obese state. So a person can be poor, they can be obese, and it definitely is a paradoxical state when you think about it. Pharmacy West Virginia advocates for a plant-based diet. We know you ate a plant-based diet today, but our definition of a plant-based diet basically is that about at least 50% of everything that a person consumes should be plants. And we emphasize fruits and vegetables. We emphasize vegetables more than fruits. And we emphasize the fact that we are trying to promote healthy food as medicine. And that's a kind of a concept that maybe has become more popular over the last few years. We like to say that we advocate for locally grown foods, and that's where West Virginia will benefit from this program. We try to support our farmers and our growers, and we know for sure, the studies have been done, that as the farther away your food is grown, the less nutritious it is, because it has to travel, and over that travel time, it loses its nutritional value. So locally grown food is the best, and we are trying to promote agriculture and support our farmers and growers in West Virginia.
So we're going to transition to talk about that initial program and the tenets of the pharmacy program. So when we say pharmacy, we're saying it with an F, and the tagline that we've sort of, put alongside of this is pharmacy, which is a prescription for produce. So in 2016, in we call it a serendipitous moment. The local urban farming group in Wheeling, which is called Grow Ohio Valley. Interesting, if you've not heard of them or look them up, they're a really grassroots and progressive organization that Wheeling's gifted with, that has reclaimed some land in abandoned areas and under some of the under some bridges, and their mission has been to provide some locally grown food to people. So they've, in as much as Farmacy has expanded over the course of 5 years, their program has blown up. So really exciting. They have a new downtown market. If you're familiar with Wheeling, it's worth looking into. Anyway, so Grow Ohio Valley, together with us, we collaborated on a project and daydreamed about a program that would provide a prescription that a patient could in turn exchange at their clinic, which would also be kind of coexisting a farmer's market, and that prescription would be exchanged for fresh produce. So through some funding, some funding that was already secured, and some other donations, we piloted a program with 35 patients, all of which who had chronic disease, predominantly diabetes being the marker that we knew we would want to track, and the one that we knew would be if the impact was going to be noticeable, we wanted to see it in the A1C reduction. So with those 35 patients, we gave them 16 weeks of fresh produce to that group. We collected some pre-program and post-program data on them, including biometric data. We took their blood, we checked their A1C and their lipid panel previous to the start of the program and at the end of the program for comparative analysis purposes. The program not only provided that prescription, which was exchanged weekly with us present, but we also wanted to stress that when we surveyed the crowd, not a lot of people were familiar with how to prepare the fresh produce that was available to them. Dr. Greco and I were working with a group of fairly unresponsive to care diabetics with, the average A1C well above 9 in the double digits, a group of people who were just refractory to care and not doing well. And when we were providing them, this was in a group appointment situation with a snack, a healthy snack, they would be receptive, but they would be unable to translate that slicing of a pepper or cutting up of a cucumber or making a salad in their own words, and they were unable to do it. They didn't have knife skills. They didn't have the ability to read a recipe in some instances. So we recognized that there was a food IQ that was fairly low among the patients that we were taking care of, patients that are representative in the state of West Virginia. So Farmacy program, one of the tenets of the program is we knew we needed to provide some form of educational component. So with a basic cooking and nutrition education, we offered that alongside of the produce to kind of equip people in a more full, comprehensive way to use what we were giving them. We're going to talk about the components of the program as we go along, but just so you know, the program has expanded since 2016, which was just our 35 patient cohort in Wheeling at the Wheeling Health Right Clinic. We're now in more than 14 counties in the state. We were able to come alongside. The Department of Agriculture has been cheerleading and campaigning for us. In fact, in 2018, Dr. Greco and I were at the WVSOM conference there at the Greenbrier, and actually the Kent Lionheart, who is our head of the Department of Agriculture in West Virginia, presented alongside with us. So they've been ambitious and encouraging. They love the idea that potentially West Virginia farmers could be upscaling their production to provide food to West Virginians in counties and places where, again, food access, food insecurity, and food deserts exist. So in partnership with the West Virginia Department of Agriculture, we have had a lot of a great positivity. Just this past year, West Virginia University, through the Health and Research Department of the university, partnered with us for a large grant that allowed us to expand to several counties in the state of West Virginia with ongoing program maintenance. The idea is sustainability. And so with this large grant through the Walmart Foundation, our partnership with the Health and Research Department, also the West Virginia University Extension, we've been able to expand this program and provide a comprehensive pool of data that we're looking at to push this program ahead for sustainability and common practice in the state.
So there are 4 basic tenets to the program. And the first one, obviously, is providing access to affordable fresh produce. The second one is providing basic nutrition and cooking education. The third one, and Amanda and I both consider this the most important, is a strong patient-provider relationship. And fourth is the health metric collection that Amanda was just talking about, as far as hemoglobin A1Cs, lipid profiles, and again, anything that a program would want to actually measure. So we've done blood pressures, we've done weights, but again, we find that because the program is about 16 to 20 weeks in length, the hemoglobin A1C is going to change the most effectively and most dramatically, I should say. So that's what we always, we try to encourage the programs that are being started to at least collect a hemoglobin A1C and then just decide what else they want to collect. So the first component of Farmacy West Virginia is providing access to affordable fresh produce. One of the ways that we try to spread the good news, so to speak, with the program is to tell clinics and counties to use your local resources. Go to your local growers and your farmers. If there aren't enough, then aggregation can be used. There are several groups in the state which actually aggregate produce for clinics if needed. Turnrow is one of them. Most times, though, with the help of the Department of Agriculture, we can actually get enough local growers and farmers involved to be able to produce enough produce for the program. If we can't, then always grocery stores and produce markets are available. If they're available, we'll seek them. But again, we like to try to get the local growers and farmers involved initially. Amanda just told you that the Farmacy West Virginia partnered with the Department of Agriculture in 2018. They help us and they help you as far as the clinics and the hospitals and the groups that want to perform do the program. They help us to locate farmers, they help us to locate growers, and they also help with the educational part of that, which is production planning. So, it's very important that a grower or a farmer knows how much produce to actually grow for whatever length of time the program goes, whether it's 16 or 20 weeks for X amount of patients. So that takes a little bit of education because most growers and farmers are not used to doing that. The second component of the program is providing basic nutritional education and cooking skills. Again, Amanda alluded to the fact that our patients that we dealt with initially definitely lacked cooking skills, definitely lacked nutritional education. So we try to provide this in the program. We have used the West Virginia University Extension program since 2016. They're wonderful, they're free. There's usually a representative in every county, and if there isn't, several counties will share a representative. They have existing nutritional programs. In other words, they have the Family Resource and Nutritional Program, which provides 6 weeks of basic education in nutrition and cooking skills. It's in a second or third grade level, so everybody can understand it. It's very simple, but it's very informative, and people tend to absorb it really quickly. If the West Virginia University Extension program is not available for some reason, or if a clinic or a hospital chooses not to use them, then they may choose to use a dietitian or nutritionist that is associated with the facility. So that's also a resource. Thirdly, back in 2016, 2017, 2018, we actually partnered with West Virginia Northern Community College, and Chef Jean, who runs the culinary arts program there, provided basic cooking skills, chopping, baking, grilling, sauteing, basic things that people may or may not know. Provided that to patients, allowed them to develop some knife skills with chopping and things like that. And he actually used the produce that was available that week through our program. So it's kind of a dual effect there with basic cooking skills plus using the produce that was available. And community colleges are available in different different areas, different counties, different communities in West Virginia. And so that may be a resource that can be used.
Not that I have a favorite tenet of the program, but this is maybe the one that I feel is highly valuable and undersold, although Dr. Greco and I believe it to be maybe the cornerstone of it all. The idea of this patient-provider relationship, and we made this a component of the program because we believe that the success of the program is only, it's as good as that relationship that the patient has to their healthcare provider. So if you've, done some outpatient care in a primary care setting, there are some long haulers in the state of West Virginia where in these small towns, there has been the same doctor or the same mid-level healthcare provider that have bedded down and maintained relationships with those patients in those areas for a long time. And that secures trust, and they become an influencer in that patient's life because they've earned the right to speak into that patient's life. When you've held the hand of someone when they've been given a bad diagnosis, or grieved with someone at the loss of a family member, or gone through, addictions recovery or homelessness or whatever burdens that, that particular patient, when the healthcare provider is involved in, the aspects of the patient's life that matter more than that. If you can remember Dr. Greco referenced the pyramid, and our role as healthcare providers is so small at the top of that pyramid when their whole life, the rest of their life is going on. So for the healthcare provider to overlook the role that they could have in influencing a patient's life is a shame. And unfortunately, for as many good long haulers there are in the state of West Virginia, there are places where there are no healthcare providers, or healthcare providers that don't have maybe a progressive vision for ensuring a relationship that would be able to impact the patient's life. So this patient-provider relationship, in terms of how it relates to pharmacy, is that we don't want just a program. We don't want to just have $10,000 sent to an FQHC where somebody's surfing out their 2-year, they're going to get their loans repaid and they're serving for 2 years. They have no intentions of staying in that rural town in West Virginia, and we're just going to give them $10,000, slap it on them, let them carry out a program. That's not how this is working. This, we believe, is an initiative to change the way healthcare is practiced in the state of West Virginia, to change ultimately the health metrics of the state. So when we're talking about, maintaining that connection, we want the program to be at the clinic or at the hospital or at the FQHC, the medical practice where the provider is and the patient is familiar with going. Oftentimes, the FQHC or in Wheeling, the Health Right, the Health Free and Charitable Clinic, it's almost like a hub in the community where patients can, they're not only receiving medical care, but that might be the place where the church food pickup is, or that might be where the pharmacy is, or they're getting GYN care there, or they have a variety of services. So it becomes a hub and the patient's familiar with it. We want that to be the case. Having that long time relationship, the provider should be able to pick the patients that would best qualify and best benefit for the program. We also want the provider to be intimately involved in the progression of the patient. So if the provider is checking in, better yet, if the provider is at the pharmacy weekly, seeing that patient, asking them how they cooked their butternut squash last week, asking them to taste test the bruschetta. If they're present, they're also validating the program for all it's worth by saying, this is just as good as you coming into the office and sitting with me. They're ensuring compliance, that the program is all that it can be for the patient. The provider's role should be to support, affirm, encourage, and to educate right then and there in a real-time process. Life is being lived at a pace that is sometimes overwhelming for patients. And so when the provider can sneak in and have an opportunity to speak, it doesn't have to be the platform of the exam room. That's often a cold and kind of dry place where the provider's stressed and the patient feels burdened, and it's an odd kind of situation. But to be in the everyday life of the patient, to be present while they are coming to this farmer's market and they're exchanging this prescription and they're seeing their provider, and we're all talking about healthy food and what we've done, and are you going to can those zucchini? What are you going to do with those? Having that type of education is a different way of educating the patient, but also very beneficial. And the patients widely receive that because it's in real time. Also, with the provider being present, the provider is the one who is providing the prescription. So very important. Data collection, although Dr. Greco and I love the way that our metrics have turned out, this isn't why we got involved in the program. We knew that we all know that healthy food affects people positively. We know that when we eat a healthy diet, we're not trying to reinvent the wheel. We're just trying to roll the wheel that already exists. So when we're talking about data collection, we just want to be able to prove for sustainability purposes that healthy food does impact the life of the person. So when we're talking about some of the biometric data, like the health metric collection, the hemoglobin A1C to measure for progression of diabetes or improvement of diabetes, in a lipid panel, we also, as Dr. Greco said, checked weight. We did some blood pressure pre and post program. Sometimes more is less. And so we collected a lot of data in order to see what we were affecting ultimately. But we also collected surveys, pre-program and post-program, which we were trying to elicit certain information. We wanted to know how much information how much knowledge did patients have on produce consumption, preparation skills of food? Were there food insecurities in the home? What kind of eating habits were a typical behavior among the patients we were taking care of? We had suspicions, and we kind of wanted to hear truly from the patients what was going on. These were anonymous, and we were able to identify the pre and post via a numbering system. So the post program, we wanted to see, did the patients like this program? Did they benefit from all of the tenets of the program, specifically education? And did they have any issues with completing the program? Was transportation an issue? Did they have some trouble with maintaining their attendance in the program? We wanted to know, was this effective for them, and in a real way, not just looking at the biometric data.
Okay, so we talk about the prescription, and this is a prescription program, but I like to reference it as the power of the prescription. The prescription versus some of the pharmacy programs, which I've seen that use vouchers, I think that the prescription gives the concept of food as medicine more credibility and validity. It gives the program credibility as far as healthy food as medicine also. So what we did is we actually wrote a prescription out. And back in the old days, we used to do that for every single prescription for medication that patients used to get. They were all handwritten. The patient would take the prescription to the pharmacist. The pharmacist would exchange it for their medication, and that's how they received their treatment. Well, with e-scripts, I guess that doesn't happen much anymore, but we have reinstated it, and we've put it into action as far as writing a prescription out for the patient, which they receive every single week when they come to the pharmacy pickup. They receive the prescription from the provider who is there at the time of pickup. And they take that prescription to the person who is actually distributing the food. And they exchange that prescription for healthy produce. And that's the way it works. On the prescription is written, quote unquote, the patient's name, 1 week supply of fresh produce, and then the provider actually signs the prescription. We collect those up during the, at the end of the pickup. We use that for verification the patient was there, and we hand it back to them next week. And we do that for 16 to 20 weeks. So some of the results, Amanda and I have, everybody knows that healthy food affects chronic disease, especially diet-related diseases such as diabetes and heart disease. Initially, we had, in the first 2 years of the program, when it was just at Wheeling Health Right, we had a hemoglobin A1C reduction of 0.4. The total cholesterol reduction of 8 points. Remember, this is only a 16-week program. What did we do? We put produce in the home. That's all we did. We did nothing else. So this may not seem like a big deal, but go read up on some of your, diabetic medications. If they can say that they can lower that hemoglobin A1C by 0.5, it's a big deal. So that was pretty close to this. So we do consider this to be a success. We consider it to be a big success, really, with just doing the produce and focusing on healthy eating. So the majority of the patients stated that they benefited from the program in lots of different ways. They ate fresh food that they normally wouldn't have. They learned how to prepare fresh food that they normally wouldn't have had or not known how to prepare. Things like butternut squashes, acorn squashes, kale. Things like that intimidate people if they never prepared it or they've never seen it. Some people never saw some of the produce that we had. So they did learn how to do that, and they felt comfortable doing it. The majority of patients felt comfortable doing it by the end of the program. As Amanda said, we expanded this year. We had 14 programs this past year, all over the state. The data analysis is still not available for everybody. It's looking good. It's looking like probably the hemoglobin A1C level is a little bit higher. We had reduced it a little bit more, up to about 0.5. That is not confirmed yet, but that's what it's looking like right now. So when I was preparing this lecture, I was thinking back to my osteopathic roots, which have gone with me over the years. And really, what is osteopathy about? It's focusing on the whole patient. And it's recognizing all the things that influence a patient's health. Their social and their economic reasons for their disease states. All those variables do affect a patient's health. And we deal with that as physicians and providers. We deal with that all the time. We just don't maybe realize it or don't, think about it. But I think this program sort of brings that out a little bit more, maybe. It makes us think about it a little bit more. What are the underlying social and economic reasons for disease states? And I really truly think that we try to do that. We try to look at every patient as an individual, and we try to help them through this program and to actually overcome maybe some of the reasons why they can't make it there this week or whatever that reason is. But we also recognize that a patient has a combination of body, mind, and spirit, right? It's not just body, it's mind and spirit also, which is obviously an osteopathic tenet. And that the body is capable of self-healing and regulation and health maintenance if it's provided with the resources to do so. And so in this case, what are we providing? We're providing healthy, fresh food for the patients.
This is a slide on funding, because sometimes when we're approached by someone who may be interested in starting a program, they feel that this may be the biggest barrier in order to get their program off the ground. And although getting funding is it's not just like money grows on trees. It has been our experience that there is money available, especially within the past couple years. There's been a push from a lot of different players in the healthcare market, including insurance companies themselves, to look into at least food as medicine and the concept of what it would look like to provide some sort of pharmacy lookalike program. So sometimes we've been approached by agencies that have funding secured, but what we've done is we've been able to, especially in Wheeling, through the local giving of the community. This is like local organizations that you might, and clubs, and like the Lions Club, or some women's giving circle, or just local organizations that try to, in some way, do some philanthropic giving in their community. This is not to be overlooked. This is really, we've sustained our program in Wheeling on local gifting. This is just what it requires, is you going to, be the bullhorn for your program and tell people what you're doing. Most people are very interested and at least inquisitive and curious. And so they're giving in this way. This isn't a grant, right? This is just a gift. And so there isn't a whole lot that you need to return to the giver. Grant funding is good too, though, and so through large federal money or the USDA, this is a little bit more where if you're skilled in grant writing, or you have someone who works with your group that's skilled in grant writing, this is where their skill set comes to shine. So in West Virginia, we have a large network of federally qualified health centers in some of the more rural and underserved areas. And often it's been our experience that we've noted that within the budget of that FQHC, the operating budget, there is some flexible dollarage that can be designated for a program like Farmacy. So we've had the pleasant experience of seeing that happen in some of our FQHCs, where actually the health center has designated the money and provided the money that the program could, at least do a pilot program with the provider's oversight. And again, it's all about talking about your program. Dr. Greco and I have, especially before COVID, but even during COVID, we've been able to, talk everyone's ear off about what we believe to be, the way that medicine should go, the trajectory for improvement of those health metrics in West Virginia. So when we have an opportunity to develop partnerships for more grant funding, we take it. We try to we always have our hand out, but we're always trying to, affirm that what they're doing with their money is beneficial for the state of West Virginia. And in terms of how, if this is something, oftentimes we're talking to groups of physicians or healthcare providers who may have some interest, but it may feel overwhelming. So this would be, if this is something that, as you continue to practice medicine, or you're beginning to, have some interest there at the school to do something like this, it would be imperative that the program is connected to some type of clinic or a medical practice, an FQHC, have a hospital partner, some medical facility that can be the hub, and having that local medical partner who would be willing to provide the appropriate patients that they feel would be eligible and benefit most from the program. So your partners, those medical partners, they really would be the ones to kind of help you determine what disease states do they want to monitor. We've talked a lot about diabetes and having that A1C reduction, and talking about the healthcare cost savings associated with the A1C reduction. That's what we've leaned into that, but certainly there are all kinds of health not only demographics of patients that you could zone in on and begin to work with, but health diseases that, like mental illness and depression. And with the pandemic, we've seen some clinics really lean into that and begin to look at how does providing healthy food affect the cognition and the mental health and the wellness overall of the patient. So certainly you want that partner to determine what disease states they'd like to have monitored and what health metrics are, what could be collected. There are barriers with collecting those health metrics. You need Certainly in some of our places, we have an A1C machine, a lipid panel machine that uses a cartridge that we, run about $12 each, and we just do a finger prick and run those right then and there. It's very convenient, but that may not be available in some places. So you want to be able to have something, picking the data that would be most appropriate to measure the success of your program. Obviously, when it's tied to a medical facility, having it either in the parking lot of that particular facility or in the lobby of that particular facility, we want it to be on-site pickup so that the patient is, again, just really paving, really just making that very clear in their mind that this is from the healthcare provider, as if they were picking up their prescription for lisinopril. They are picking up their cabbage, and that is all part of their health maintenance and ongoing change for them. So we have, there's some flexibility in when to collect these, but ultimately it seems to be easiest that on the first day of the program and the last day of the program, you go ahead and you do those finger pricks, you have them complete the surveys right in, your presence. Do the blood pressure, depending upon the resources available at that clinic, you may have some limitations, but this is in many of the FQHCs, certainly at Wheeling Health, right? It was our experience of an all hands on deck, get the whole clinic on board. We are all doing this. And this is, our ongoing effort in places is to really get that engine grease so that the program can run smoothly with as many available volunteers to help it work. And you can also, health metrics can be made a part of the patient's chart. We're taking an A1C if it's an appropriate time at the 3-month interval that the patient would normally have an A1C if they're a diabetic, then it's completely appropriate to use those health metrics at the time. Certainly if they've had a venous lab draw recently, you could just do a post analysis and compare from the chart in, June versus September, and, just do a comparative analysis that roughly gets the time frame that the patient was involved in the program and ate the healthy produce during that 3-month window. You may want to, in terms of getting started and moving this program along, exploring and knowing what local resources are available. This is what Dr. Greco mentioned. It can't be, one thing that West Virginia University has done well is just really splinter out in the state. So the extension service, again, those representatives are trained in health education. That is what they do. They are providing that service free of charge to residents in the state of West Virginia. They've long time been known for their diabetes, their efforts with Dining with Diabetes, or their programs to influence the way people are eating. However, they have trouble getting traction. They have trouble having a platform. They rely on basically flyers stacked up at, local hair salons or the soup kitchen, and people would see those flyers and enroll in their programs. So they benefit from being connected to a clinic as well, so that they can have enrollment in their programs that already exist. Again, not reinventing the wheel. These extension representatives are trained and they're willing to work with us. So having a good relationship with whomever your extension coordinator is in your county or your region is imperative, because they can help you. You don't need to prepare an 8-week class on how to cook because they've already done it. So using the resources available to you where you are is good. Because we know that the way our patients live, oftentimes they're spread very thin. Just returning, as you know, for a 3-month wellness visit can be a barrier for many patients. Transportation, work schedules, childcare, illness, extended family, whatever variable is at play at the current moment, things limit the patient from accessing healthcare. So when we want to emphasize education, how do we do it? And really, this is where, it's in real time. You're actively out there educating the patient on, how easy it is to chop and prepare a salad, to get that produce prep before they get home, how broccoli florets are, probably what they prefer, blanched as opposed to raw broccoli. Just being able to speak into the life of the patient in real time, on-site education during the pickup. this has really just been a fun thing for patients to be involved in as well. They are learning, but it is actually fun because they're seeing a recipe demonstrated in front of them. The written recipe often is, again, at that second or third grade reading level, but they're seeing it. Oftentimes visual learning far outweighs, written, just being able to read the recipe. When they see what saute means, it's a little bit more impactful than just reading about what saute means. So they've seen the recipe prepared and then they taste the recipe. And this is obviously the funnest part and validates what we've been saying, that healthy food can taste good. And so the West Virginia University Extension Office, we can't say enough good things about the way that they have already this in place, the ability to do this on site, really great. If your community has a diabetic educator, then you need to meet that person and you need to be using that person in your program. West Virginia has a limited number of nutritionists, diabetic educators, dietitians. This is a shortage area in our state regarding, in healthcare provider shortage areas. This is just one of those areas. So if you know somebody in the area that's trained or is seeking to be trained, capitalize on that and put them to use in your program. And again, community colleges, just when thinking about what partners already exist in your community, if you have a community college, oftentimes there is some degree of programming available there that they desire an outreach platform, they just don't have it. So connecting with you, connecting with the healthcare world is really beneficial for them.
So we've learned a lot of things in the last 5 years, and we've just put a couple down here. When we give this talk to people who are actually going to start the program, we list a bunch of them. And actually, there's lots of those listed on our website, which I'll give to you in a little bit. But some important things that we've learned is that patients should be able to handle their produce. It seems like a simple thing, but we recommend that the program actually use, hands-on type of thing versus a pre-packed box, right? So a lot of programs hand out a pre-packed box, but with the handling of produce comes education, comes verbal exchange, comes interaction with the person handing out or advising the patients on which vegetables to pick this week. So that all happens, that whole interaction of, the exchange of the vegetables for the prescription, that all, just gives so much more validation to the program, and the educational component that happens there is amazing. Patients learn and I'll go back to my old butternut squash story, but a butternut squash can be very intimidating. How do you even cut it open? Do you cut it open? Do you peel it? Whatever. So that and eggplants and kale and things like that that people may never have seen or have seen and just not known how to fix, that all happens during that hands-on exchange during the pickup. We do discourage, like I said, the use of pre-packed boxes, but COVID-19 changed the rules a little bit for us. The state came down hard on farmers markets. They implemented a ton of rules that we had to follow. And of course, the pharmacies are considered a farmer's market in the state. So we did have to use pre-packed boxes, and all of our sites this year did that. And it seemed to work out okay. We don't want to do it again next year if we don't have to, but that was a little bit of a change for us this year. As Amanda said, as I said before, there are major barriers to participation with our patient population. And those include transportation, probably number one, work schedules or illness or extended family issues, childcare, things like that are all major barriers to participation. And so what does that mean? That means that the patient may not be able to get there during that 2-hour window of pickup. So what we were doing was a 9 to 11 pickup on one day a week, which is a Thursday. And most places do either a 1 to 3 hour pickup. So if a patient can't get there for whatever reason, the clinic needs to be flexible. They need to be able to either hold the produce back till the end of the day when the patient can get there, or they should have a designated family member or friend that could be able to pick that produce up. That's very, very important. Otherwise, you know, the patient may never get the produce that week. So I think most of that's doable for people. They don't even need refrigeration to do that, especially if it's going to be held till the end of the day. So this was really interesting. I attended a Zoom meeting on March 26th, which was funded by the Rockefeller Foundation Food Initiative. It was called Mainstreaming Prescription Produce Programs, a policy strategy. And this was amazing for me because this is what I've been doing for the last 5 years. And this is what Amanda's been doing. And this Zoom meeting helped us to answer some questions that we had. They finally have, you know, Rockefeller probably invested a ton of money for this, but they're trying to bring out the fact that that produce programs are important and that they would improve and they would prevent chronic disease. And that's what the information through this whole policy, you know, change type of program, they came up with this information. They've proven that they work, and they're basically trying to find some sustainable implementation. And what that means is trying to incorporate the produce programs into the Medicaid and Medicare systems, Medicaid programs, and existing programs like WIC or SNAP. And SNAP is, you know, the new name for food stamps, which SNAP actually has already incorporated some of that, but the other programs have not. But there are ways that exist already for Medicaid and Medicare to implement these programs. There is funding available to do that. It's just getting everybody on board and figuring out how to do it. I did find out towards the end of the Zoom meeting that I was probably one of the people that was interviewed for this data collection process. Google had emailed me back, I want to say 2019, I think, or 2018, I can't remember, one of those, but I answered probably a 45-minute series of questions for the woman who was, you know, interviewing me. And I realized that at the end of this Zoom meeting that we were the one site in West Virginia that was marked on the state map for having all the components of what they considered to be a good program. So that was very, it's made me feel great. So anyway, I think that what we have been trying to work on for the last 5 years is to try to create this program so that it can become sustainable. And we really think that at least through the Medicaid system, it can become sustainable. We have more information on the program, pharmacywestvirginia.com. If you get a chance to look at that, that's our website. We have a how-to tab, which gives a detailed description of how to implement the program, some of the history of the program, and we have a video also on there that would be nice for you to watch because it is a history and implementation video. So Pharmacy West Virginia prescriptions for produce, one of our, you know, just our feelings, our thoughts, our, you know, what we consider to be true is that access to healthcare is useless without access to healthy food. And you can see Hippocrates said the same thing 2,000 years ago, so it's not new. He said, "Let food be thy medicine and medicine be thy food." So that's our mantra.
Great, and they heard that this morning out at the farm at Tommy Lou's operation. Good. Thank you very much. This is great stuff. We'll probably have some questions here if you can hang through. I first am curious about how the two of you sort of got partnered up with this. Who brought it up first, or who had the first passion? I know you work together, at least in the same vicinity.
Want to answer that, Amanda?
We just call this like a serendipitous moment. I worked at Wheeling Health Right for 11 years, and Dr. Greco volunteered at Wheeling Health Right. And actually, Dr. Rick Greco and the residents had their outpatient care at Wheeling Health Right as well before OVMC closed. So we've all kind of just been in the same world for as long as I've been in Wheeling. And Dr. Greco has always been a great influencer to me in terms of the way that she's practiced medicine in a holistic way, letting that the osteopathic background influence the way that she practices medicine. That wasn't my experience with other providers that I've worked with, so it was encouraging. And she's always stressed healthy eating. In my observation of her and the way that she's talked to patients, healthy eating has always been a part of the way that she's practiced medicine and encouraged patients to eat. So I think that was something that she had brought up, like, wouldn't it be great to, be able to give patients a prescription for healthy food? And nearly at the exact same time, we had been spending a lot of time with the developer and the organizer of Grow Ohio Valley, that urban farming group, and we were, and it really was just sort of like a well-timed conversation, and that he had in his own mind, seen something similar, or at least read about something similar, where a healthcare provider was using food as medicine in a real way. And he brought that up to us and said, do you think that would ever be feasible? And we really just ran from there.
Yeah.
I have Tommy Lou Rapis here with a question. Did you have something, Carol, you wanted to add to that? Sorry.
No, go ahead.
Tommy Lou's the owner and operator and whatever of T&L Fruits and Vegetables.
So I am so glad to meet you. I have been following you since 2016 online. I know some of the farmers that provide produce for your program, and I have been wanting to do something similar here in Greenbrier County since 2016. So I'm thrilled that I get to meet you and see you.
That's great. If we can help you in any way, we are free of charge and available at any time.
Okay, so my question to you is, have you thought of any other diseases that you want to track?
Well, so the easiest to measure is what we've already done, right? We've already done the cholesterol, we've already done the diabetes, and the reason to track those is they change, the metrics change so quickly that they're easy to track. And at this point, we need data to be able to make our program sustainable. We need to be able to present it to an insurance company. We need to be able to present it to the Medicaid system in the state. We need to say, look, this works, and this is why, and this is how it works. But we have thought about a lot of different diseases. And I'll tell you what, the one we would really love to do is depression and anxiety. We would love to do mental health issues, because we think that that's so understudied, I think. And it's so prevalent in the state that it's just as high up there as diabetes and heart disease. So we would love to do that.
I'll have to jump in on that because we just finished a small study here with one of our graduates down in Princeton. Can't say her name off the top of my head, we've been working together, but over 600 responses to a survey on depression and anxiety and their eating habits. And we're looking for a publisher now. It's been to about 3 places, hasn't been picked up yet, but definitely the anti-inflammatory diet, and that's what it is, that they're using. And using just dietary history, not any controlled study, just a survey of the history. And it showed a great, significant improvement.
That's great.
So it's out there, and there's certainly an awareness for it, but you're right, it's the next place. And you have, I don't know if you have a facility there, but certainly Pittsburgh, where you have a larger patient population and all. But yeah, that's definitely very important piece, and it's the mind side of the mind, body, spirit.
That's right.
I wanted to say one thing before I forget it, and that is Andrew Taylor Still, one of his most famous quotes is, finding health should be the job of the physician. Anyone can find disease. So disease. So, it is in there with Hippocrates, even though he didn't talk a lot about nutrition. It was finding what'll keep us healthy. I have one part, and then let's see if there's any questions around the room. Good, I'll come right to you, Chris. Well, I'm going to get his question. How does the farmer at the farmer's market figure what part is theirs and how much is a week's worth of, I mean, I'm a little bit unclear on that relationship and how they would fill. Would they go and get 6 jars of honey and 3 jars of syrup and go home happy?
So you mean, are you talking about the production planning part of this, or?
Yeah, just how do they cash in their prescription?
Yeah, so the farmers are paid up front. So,
Okay.
you know, if a farmer is going to commit to this program for 16 weeks, you know, what we do is we supply 15 to, depending on the program again, $15 to $20 a week per patient for produce for 16 weeks up to 20 weeks. And the farmer is paid up front.
So it's really a CSA kind of arrangement.
Right.
Community supported the agriculture arrangement. How does the patient then get to select, because they're choosing was one of the issues you said was important.
Okay,
Important
so
factor.
there's a certain amount of produce depending on the time of the season, right? Because we're
Right,
using
sure.
we're using local growers. They are presented with at least 7 or 8 different vegetables. But they are advised, encouraged to take all of those vegetables. And it's not like they get to pick and choose that other than handling the produce. So they handle the produce, they pick one tomato versus another tomato, or one squash versus another squash, but they're encouraged to take every single vegetable. And like I said, there's about 7 or 8 different types of vegetables every week.
And it depends upon
Okay.
what's the season.
Yeah.
Great, sure. Chris?
My name's Chris. So before medical school, I did some work in nutrition and fitness and all of that, and I plan on going into psychiatry. And I was curious to know what resources you might recommend for somebody like myself who's interested in a new field within psychiatry, which is integrative psychiatry that does look at nutrition and fitness and these other sort of markers to help improve mental health. I know that there are some programs, some residency programs that will affiliate themselves with different institutions to help with some of that integration. Like there's a place in Arizona, it's mostly in the southwestern states, to do some of that work. But I'll be up in Pennsylvania, and I was just curious if you had any ideas about what I could continue looking up for myself, for my patients.
So, not exactly, but so there's the field of integrative medicine now, right? Isn't that a new field since I was out there? So you're talking about combining psychiatry with that field? Is that what you're talking
Psychiatry
about?
is so within the field of psychiatry, there's a new development of something called integrative psychiatry, which is essentially
integrative
integrative medicine within the field of psychiatry. So that's when they're looking at nutrition and all of that. So I was just curious, you had mentioned wanting to do a study looking at depression and anxiety, which makes me think that you have some resources or some ideas about, you know, what to look into with regards to the research that's currently out there or what you would like to see done.
Well, I know what I'd like to see done, but I can't give you any specific programs or anything like that right now. I'm sorry about that, but what I'd like to see done is just what Dr. Foster's already talked about. More research into how diet affects, you know, mental health. So, hey, God's wide open for you.
I'll be sure if he
Especially,
gets.
Go ahead, Amanda.
we talk a lot about there's an opportunity in Wheeling now to work with children who are have high ACE scores, which is that you know, like level of trauma sustained in childhood, and you know how does that bear out in adulthood. And what we see in, you know, adult clinical medicine is that, there's high rates of obesity, there's high rates of fibromyalgia, there's high rates of kind of chronic pain and just those type of really nagging diseases and chronicity that is hard to correct. And so, there's probably a wide open field to look into what happens in, early childhood and young adulthood in terms of establishing a foundation for later in life with inflammation and chronic disease. Pretty curious.
Yeah, so we're going to get involved in a program in Wheeling. It's going to be called Edible Mountain, and it's a program that's going to incorporate a lot of different things, including pharmacy for children, an educational component of that, plus also art therapy, physical activity therapy, things like that. It's going to be all encompassing for about 1,000 kids. That are considered inner city in Wheeling. So we are just getting started on that program that's going to start, I think, this fall. There's always room for help there if you're interested.
Well, I don't see any more questions here. Anyone? Good. Well, we really appreciate you taking the time and for actually founding this in West Virginia. Probably one of the best places to study and look at. Certainly with all the major degenerative health diseases, and we're close to the top. Well, thank you all very much.